Great. Okay, so, oh, sorry, Suzanne, just one sec. So I just want to quickly welcome everyone and thank you for coming to today's webinar. This is part of our series around the standards that will be implemented in 2025 in January. So we're doing a webinar series to help practices and other community partners understand some additional details about each specific standard that we're covering in the webinar series. And also ask any questions that folks might have at this point about these standards. So today we're talking about a new standard in the model. It's brand new in 2025, and it's healthcare cost navigation. So I'll be turning it over to my colleagues, Suzanne and Becky, who will share more information with you about this standard. And then at the end, we'll have lots of time for questions as well. So
great. Thanks, Amy. My name is Suzanne Jefferson, and I'm an improvement specialist with the PCPCH program.
And I'm Becky Velasco. I'm a verification specialist with the program. Thank you so much for joining us for our webinar on PCPCH Standard 5B today. It's going to be about healthcare cost navigation.
We'd like to kick off our webinar with just a few webinar logistics and Zoom etiquette reminders. First, this webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization information up. And any questions and comments you may have can be put into the chat at any time during our presentation, and we will answer them during the question and answer session at the end of this webinar. Here's an agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we will dive deep into PCPCH Standard 5B, Healthcare Cost Navigation. Then we'll share some additional PCPCH resources and upcoming learning collaboratives. And lastly, we will have some time for your questions. Again, we encourage you to drop your questions into the chat during our presentation as you may think of them, and we'll get to them during the Q&A session at the end of our webinar. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support Oregon Health Authority's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address health inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. For more information, we encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is on our website.
Great, thanks, Suzanne. Let's go ahead and start with an overview of PCPCH Standard 5B. PCPCH Standard 5B is in Core Attribute 5, Coordination and Integration, which, from the patient's perspective, means help us navigate the healthcare system to get the care we need in a safe and timely way. The intent of Standard 5B is that cost of care can serve as a barrier to patients receiving primary care, adhering to recommended treatments, and establishing a trusting relationship with their medical home. State and national assessments have found that many patients delay or go without medical care due to cost concerns or uncertainty, with the proportion being higher among specific ethnic groups, geriatric populations, those who are low income, and other groups. PCPCHs can reduce these barriers by increasing transparency with regards to the cost of visits, services, treatments, and medications, and assisting their patients in navigating their payment options. This standard includes 2 measures. 5B1, PCPCH informs their patients of preventive services that do not require cost sharing. This measure is worth 5 points. And 5B2, PCPCH assists its patients in navigating the cost and payment options for their care. Excuse me, I misread that. It's 5B3. This measure is worth 15 points. And 5B is a select all that applies standard, which means practices can attest to both measures and earn a maximum of 20 points.
Next, I'll cover the specifications for Measure 5B1. A practice is meeting Measure 5B1 if it provides patients with culturally and linguistically appropriate information about its most commonly offered preventive services that typically have low or no out-of-pocket costs with insurance. For example, services with low or no co-payments, co-insurance, or services that don't require deductibles. Practices may include this information during patient registration, as part of preventive service reminders, welcome packets, web pages, appointments, scheduling processes, or other avenues that can reduce cost concerns patients may have in scheduling or following through with preventive services. Ideally, practices should strive to promote this information in a variety of ways to account for patients with health literacy barriers, those with primary languages other than English, and those generally unfamiliar with the healthcare payment system. When relevant, communications about cost should clarify which services are considered part of the preventive appointment and which may require additional cost sharing. Examples may include subsequent tests, follow-up appointments, referrals, or specific diagnoses. Patients should also be directed to confirm co-pays or out-of-pocket costs with their personal insurance plans to help reduce false expectations or surprise bills. Here's an example of what Measure 5B1 could look like in your practice. After assessing its payer mix, a practice includes in its patient welcome packet and on its website information about the preventive services it offers that are typically free under Oregon Health Plan, Medicare, and the private plans that its patients use, along with a disclaimer for patients to confirm with their individual plan. The practice includes this information in both English and Spanish due to the proportion of its patients with Spanish as their primary language. Here's another example of what 5B1 could look like in your practice. A practice incorporates cost-sharing information into its automated service reminders for each of its most common preventive services. For example, when sending reminders to patients over 50 who are due for breast cancer screenings, the practice includes in these communications a reminder that these services are fully covered for this age group by most public and private health insurance plans, along with a disclaimer to confirm with their payer. As you are completing your PCPCH application, we strongly recommend you gather and collect all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program to demonstrate your meeting Measure 5B1. Evidence of your practice informing patients of their most commonly offered preventive services that are free or low cost with standard insurance. This could be demonstrated through screenshots, examples, communication materials, evidence of workflow, etc.
Now let's review Measure 5B3. A practice is meeting Measure 5B3 if it provides at least one cost coordination service for its patients. While PCPCH Measure 5B1 focuses only on preventive services offered by the practice, PCPCH Measure 5B3 encompasses a broader range of healthcare services, tests, treatments, procedures, etc. Cost navigation services provided by a PCPCH may be general or specific to individual insurance plans. A practice may deliver general cost navigation services in the following ways. It provides patients with diagnosis codes and CBT codes or official names of internal services that they can use to acquire cost estimates. Or they work with external specialists to obtain CPT codes for frequently used external services, tests, and/or labs, and shares this information with preferred patients. A comprehensive list of general cost navigation services can be found in the Technical Assistance Guide. A practice may deliver individual insurance plan navigation services in the following ways. It provides patients with estimates of how much a visit, service, test, or treatment at the practice will cost them based on their specific health plan. It provides individual patients with estimates of how much a prescribed medication will cost them specifically based on their plan. Or for frequently used external services, it provides individual patients with estimates of how much an external service will cost them specifically based on their plan. A comprehensive list of individual insurance plan navigation services can be found in the Technical Assistance Guide. The following notes are important to highlight as part of the specifications for Measure 5B3. Practices may provide cost navigation services directly. This could be through care coordinators, patient navigators, traditional health workers, etc. Or practices can provide cost navigation through a partnership with external entities such as payers, community-based organizations, contractors, or other organizations. Practices may choose to offer these services to all relevant patients or target specific patient subgroups based on financial need or other barriers to healthcare cost navigation. Examples of specific patient subgroups include patients who are low income, experience low health literacy, speak primary languages other than English, who are uninsured or underinsured, etc. And practices must ensure that patients are made aware that these services or resources are available to them. This could be during patient orientation or in welcome packets, on the website, on posters, etc. At a PCPCH site visit, you would need to provide the following documentation to demonstrate you are meeting Measure 5B3. Evidence demonstrating the types of cost navigation services provided. For example, written policies or procedures, workflows, your EHR tool, your web page, or any posters, patient materials, or evidence of other communication.
The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through December, and you can find a complete list of topics and registration information on our website. The next 3 webinars are listed on this slide. We hope you'll join us, but webinars will also be recorded and posted on our website if you can't make it. This final slide is a list of additional resources you may find helpful. The first is our PCPCH program website. The second is the 2025 TA Guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources webpage. Next, the Community Engagement Report and Evaluation. And lastly, you are always welcome to reach out to the PCPCH program with any questions through our program email. Right, so that concludes our webinar on Standard 5B. Thanks so much for joining us, and Amy will help us go through some of your questions.
Thank you so much, Suzanne and Becky. Before we dive into questions, there's no questions in the chat, so I'll give folks a few minutes to add them if they want to, but as you're thinking about that, what you might want to ask, I'll just add that cost barrier was a topic that we heard frequently when we were conducting our community listening sessions in 2021. So as in preparation for these revisions to the PCPCH program standards, our team did a series of community-based listening sessions with community-based organizations, various PCPCHs, and cost was a barrier that came up repeatedly, almost at every session. And so we really wanted to, we felt it was really important to address that within the PCPCH standards. And so we worked with the advisory committee who helped us develop this standard and made that part of the model. Again, just a really direct response to what we were hearing very loudly and very often from people in the community. So trying to think about ways that primary care practices could help with that barrier, although certainly not eliminate it or do all the work around that, but really thinking about what were some ways that primary care could help. So this is the standard that the advisory committee came up with based on that input. So I just wanted to share that as well. So it's not just that we hear this nationally in research, although that is also true. We heard this directly from people living in Oregon. So, so I just want to add that. Let's see. So it looks like there is a question. So Jessica says, would advertising a sliding scale fee be a resource that would satisfy measure 4B1 or 4B3? And then it looks like Jordan also says, yes, she would like to know that. Okay, so a sliding scale fee. So that's a good question, and not one that we talked about with our technical advisory group when we were developing this measure. So sliding scale fees, it depends on what you are including, I think, in your sliding scale fee. If you're just telling your patient if you are at a particular income level, then you would pay less for our services. That wouldn't necessarily help them understand what the full picture would be of their healthcare costs. They would only know sort of what they're having to pay your practice, but they wouldn't really know like what the total out-of-pocket cost might be if they need specialists or if they need additional information. So my initial reaction is that could be part of a strategy, but maybe not the entire strategy. But I think I would defer to the others on the PCPCH team to see what you think, and we might have to go back and talk about that. We actually didn't have that come up at all. I'm surprised, actually. So I don't know if folks on the PCPCH team have any other initial thoughts on that.
I agree with Amy that it would have to be kind of specific to the preventative service or specific to the test or service that the patient is having done, rather than you get 30% off. When I was in clinic, we did offer that to patients. And during checkout, I would sit with them and we would get their insurance on the phone and we would find out, or excuse me, not their insurance on the phone. We would go through with the billers of the clinic, ask how much it was for that procedure, whether it be, a removal of a wart or something like that. We would call the billing with that CPT code. We would find out what the charge was. We would take that 30% off. And then I was able to tell the patient right then and there what the charge was going to be with that discounted sliding scale. So they would need to be something more specific like that. And that could be in your workflow. It could be in your policy that is what you're doing for these patients. And that would suffice, I think, for probably both measures. If you're doing that for a particular subset of patients, you wouldn't have to do it for all of your patients. We kind of wanted to have clinics know that that's not something we expect you to do for every single patient. You can select a subgroup to do that for. But I think just saying we have a sliding scale, again, we didn't come up or discuss that before, but I think it would need to be more specific.
Mm-hmm. Thank you for adding that, Amber. And thank you for that question. That's why I said it before, if you've joined us for other webinars, we always appreciate the questions that we get on these because it helps us to make the technical specifications better and more refined, because we certainly, we work with community partners to develop these tech specs, but we can't cover it all. even though we try our best to. So again, we really appreciate the questions that help us to think through some of these things as well.
And I just add,
oh,
sorry, go ahead.
Yeah, no, go for it.
I would just add too that a great way, as a great rule of thumb would be to put yourself in the patient's perspective and ask, would this service reduce my cost uncertainty or cost concerns? So for example, if I was a patient and I just heard that there is a sliding fee schedule, that wouldn't tell me whether or not I can afford the service. Like it might give me a clue, but I really wouldn't know, okay, can I afford this service or not? And so that's kind of a good rule of thumb.
Yeah. Thank you for that, Rachel. Okay, so let's move on to the next question. It says, a barrier I notice with commercially insured patients is not wanting to schedule an appointment based on not being able to afford copays and deductibles, but I don't believe any help can be given to this group of patients. So I would say with regard to payment relief, you're right. I mean, you know, depending on what their plan is, they do have specific copays and deductibles that they have to be able to meet. So there wouldn't be necessarily any financial help that you could provide for them. But I think if you did kind of what Amber was describing earlier, where you sort of reach out to the insurance company on their behalf and sort of help them figure out what those costs might be, that could help them make a choice about whether they want to have that service or what they can afford or what they can't afford. A lot of what we heard, although I mentioned we heard about the cost being a barrier, which was certainly something that was very important. We also heard that people just don't know who to call at their insurance, and because it's so complex, especially for people who maybe might have health insurance for the first time, or they have not had great experiences with, you know, government systems or big health insurance plans, things like that. There might be a lot of intimidation about reaching out, not knowing who to reach out to. And so the practice as a provider, as a medical provider, and somebody who probably knows the system pretty well, you could really help that patient understand what those costs are, even if you can't help them financially pay for those costs. So that's kind of what we're trying to get at with this measure, is that navigation piece, right? So like and I mean, obviously, if your practice can provide sliding scale, that's awesome too. But really, it's that helping them understand what those costs might be that is really the heart of this standard. So, and that applies to any payer. Like it would be commercial payers as well, who can sometimes be the most challenging. So that's a good question. I hope that was helpful. So the next question is, how about good faith estimates? How does this interact with 5B? I think that kind of what we were describing before, if the good faith estimate is really clear, you know, if it focuses especially on like the preventive services for, you know, 5B1, then I think that would be fine. We'd have to see sort of we probably would want to see what was included in your good faith estimate as well, kind of what information you're providing to the patient. But as long as it's, you know, detailed, I could see that being helpful. Oh, and I see you also put a link to the CMS guides for good faith estimates as well. So we can check out that resource and think about perhaps including that in our TA guide as well. I'll the team to see.
Amy, if I could add, so the good faith estimates are great. But they're intended for patients who don't have insurance or are going to be self-pay, going to choose to self-pay. So that's kind of an isolated section. That's just one thing to keep in mind.
Good. Thank you for that, Meg. So another question. So it looks like one practice has a Medicare and Medicaid specialist integrated, available to help with understanding the cost of services. That's great. That's really great. Yeah, that was probably very, very helpful. Other questions? That's all that's in the chat. So
I was just going to add to what Jessica said, that I think that's a good way to demonstrate how you can use someone outside of your clinic to help you with this measure. So I think that's a great example of how you can do that.
Yeah. So another question, does 5B1 need to apply to all patient populations or is it intended for subpopulations? That's the choice, that's up to the practice. So so if you have the capacity to provide that for all your patients, that would be amazing. But if you don't, and you want to sort of use specific categories, or you want to figure out which patients in your practice might need that the most, based on some of the characteristics that we talked about earlier that Becky talked about, then you can certainly do that as well. So that's a good question.
I'd just like to clarify too, I think Jessica's asking about 5B1 specifically, and that one is all patients. The
I'm
5B3
sorry. I
allows you to
apologize.
target or allows you to choose your whole, but for 5B1, that does apply to just your general patient population.
Thank you, Rachel. I misread that, so I apologize. Thank you for clarifying. So just ignore what I said and listen to Rachel. So sorry about that. It's Friday.
I'd
Other
also
questions?
just like to quickly add, just to make it, just in case it wasn't clear, page 124 of the TA guide for 5B3 has a long list of different cost navigation services that we accept. We just included a couple in this presentation today, but there's a lot more options that you can read through and see if it applies to what you're doing.
Yes, thank you for that. Other questions? I'm curious if anyone is already doing this work. If you'd like, I know we know some practices have gotten a jump start on some of the standards and measures in the 2025 model. We also know that this work, the specifications for nearly all of the new measures have been based off of what we've also heard other practices are doing. So I'm curious if anyone on the call today is doing this and you'd like to share. We are hoping to have some additional learning collaboratives at the beginning of 2025 for more peer sharing. But if anyone is doing it now and wants to, speak out, we'd love to hear. I'm sure others would love to hear how you're doing it. No pressure, but since we have the time. Okay. Does anyone have any other questions about other measures? We certainly can, I know there's lots of other measures in the model, so we also want to think about, since we have this time here, you can ask us about other things as well. Either things we will be covering or things we have covered that have come to mind about the model. Okay, well, I'm not seeing anything. I will let folks know that some of our staff are going to be presenting at the Oregon Rural Health Conference in the beginning of October, and we'll be covering this measure in a bit more depth, and also talking about some specific strategies for rural health, for rural practices around this measure. So if you are attending the conference, we'd love for you to pop in and learn more about some strategies around this measure, as well as some other measures too. We're also covering some strategies for other measures as well for rural health purposes. So with that, I think we'll end. And I just want to again thank everybody for coming today, and just to also let you know that you can reach out to us at any time through our PCPCH program inbox. Rachel on the call today answers our inbox questions, and we're happy to provide you any support you need around this particular standard or any others in the model as they come up. So great. All right. Well, thank you, folks, and we'll see everyone next time.
Bye.
Thanks, everyone.